It's important that we acknowledge and understand the existence and impact of unconscious biases in the healthcare setting. This is part 1 of 2 videos for this module. By the end of this module, you will be able to describe unconscious bias, explain how unconscious bias may negatively impact health equity, and identify ways to develop your clinical skills to improve equitable collaboration with patients. In this video, we are going to review 2 articles. The video is going to intermittently pause and a question will appear on your screen. In order to move forward in the video, you have to provide some sort of response to that question. You can pause, stop, or even go back at any point if you want to. All right, let's get started. So we will begin with an overview, which is probably more of a review for most of you. Implicit biases are the subconscious heuristics or mental shortcuts and associations that we have for words, products, ideas, and groups of people that have been built from our experiences, the media, society, and countless other sources. While these biases often help us cognitively navigate through the world, they can lead to unintentional prejudices. Having implicit biases about a group of people is neither wrong nor any kind of ist. Everyone has a bias of some kind. It is important, however, to be aware of our own biases so we can make sure that they're not influencing our overt behavior. The first article we discuss is by Augustus White and Beauregard Stubblefield Cave. This is a part of your required reading for the week, so be sure you read and understand it in its entirety. You can access the full article on Canvas. So as a medical SLP, you have to have a solid understanding of healthcare disparities. You're going to need to be aware of the groups who are impacted the most and understand how healthcare disparities and unconscious biases impact the lives and the care of the people we serve. With this information, you can take steps to reduce and hopefully eventually eliminate the impact of your own implicit biases. This article reviews the non-socioeconomic factors that contribute to healthcare disparities. So it starts by outlining the groups who often receive a lower quality of healthcare. This list includes, but is not limited to the following: women, African Americans, Appalachian poor, Asian Americans, elders, immigrants and refugees, individuals living with disabilities, Latinos and Hispanics, members of the LGBTQ+ community, Native Americans, overweight people, prisoners, and some religious minorities. The article goes on to identify background considerations that impact every patient-clinician encounter. These factors can potentiate unequal treatment, so it's essential that we're aware of what's happening so we can take steps to combat their negative impact. The first background considerations they discuss are unconscious bias, stereotyping, gender bias, institutionalized, ambient, and internalized racism, sexual orientation, limited health literacy, interpretation quality, and cross-cultural communication challenges. Each of these factors has been proven to negatively impact the patient's care and therefore their overall health outcomes. The article describes each of these factors at length and provides references to some pretty grim statistics. For example, in one study, physicians were 24% more verbally dominant in conversation with their African American patients than with white patients. They also engaged in 33% less total conversation with African American patients as compared to their white patients. This means African Americans are given less time overall to speak with their doctor, and even when they do speak with their doctor, they get less time to share their own thoughts and ask questions. Another shared statistic is that Black women are significantly less likely to receive a referral to a cardiologist or for a specialized treatment when they present with the same cardiac symptoms as other groups. You do need to read through the full article because it'll give you more information on each of these factors, but again, we really need to understand the negative impact that this has on the people we work with. The next background considerations they explore are more specific to the clinician and the organizations that we work for. Cultural humility and identifying and challenging power imbalances in the clinical relationship are important areas to consider when working as a medical SLP. Using patient-focused care and empowering our patients can enable them to be more equal and effective partners in their care. Promoting institutional accountability is also essential. Hospitals and healthcare organizations hold a powerful role in service delivery. They should be engaging in activities like providing consistent and ongoing training to clinicians and surveying the patients in the community around them. These types of activities really, it kind of just puts forth an effort toward ongoing quality improvement. And that in turn, if done right, can reduce unconscious biases that occur at their facilities. One quote that kind of stood out to me from this article is that no individual clinician can hold an entire institution accountable, but every clinician has the ability and responsibility to advocate for their institution's provision of culturally competent care. The rest of the paper outlines a set of guidelines for clinicians to implement in their practice. This 18-item checklist is not specific to SLPs, but it does provide us with suggestions that we can adapt in our care for patients in medical settings. We are going to discuss the items from this checklist at more length when we meet in class. I do encourage you to read through the list before we meet so you can begin thinking about actions that you already take to improve your patient's health outcomes, as well as changes that you want to make as you begin your clinical rotations out in the community. All right, we will now discuss an article by Dr. Clarissa Kripke. You can find the full citation at the bottom of this slide. The article begins with a case scenario from a healthcare setting. In this case, the patient is a 58-year-old non-speaking male with an intellectual disability who is admitted to the hospital for cholecystitis or swelling of the gallbladder. This patient has a past medical history that includes well-controlled seizure disorder, secondary Parkinsonism from medications, and diabetes insipidus. For this condition, surgical intervention was the best option, and the procedure was uncomplicated. Due to underlying disability and the need to drink a high volume of water to maintain a sodium balance, his recovery was slow. 6 days after surgery, he was able to swallow some medication, but still required a nasogastric tube for nutrition and hydration. At this point, the hospitalist decided to invite the hospice team to discuss goals of care. The hospice team agreed to the referral. The patient's family was on board. However, once the patient's primary care physician began to ask more questions, it became clear that the recommendation for hospice stemmed from a misperception of the patient's quality of life and pressures to advance a discharge rather than specific medical indications. Within a couple months, the patient had returned home and was back to his previous baseline function of attending a day program and eating his favorite foods. This case study leads us to a discussion. From this example, we learn that false assumptions about a patient's quality of life can affect prognosis, the treatment options that are presented, and the referrals that we offer. As a healthcare provider, we need to actively consider that a complex disability does not equal a terminal illness, and that disability does not equal disease. Unconscious biases about disability can lead healthcare providers to make worse decisions about a patient's care. This article also provides common communication pitfalls that are seen in healthcare settings. The column on the left-hand side demonstrates things that we frequently hear from healthcare providers, statements that are written in notes, such as, "This poor, unfortunate patient suffers from," or statements to patients, such as, "I understand you don't want to be dependent or a burden to your family." The column on the right-hand side shows us ways that we can reframe this communication to be supportive and helpful. Those same phrases can be stated with respect, such as writing, "Mr. Smith is a 56-year-old man who uses a wheelchair and volunteers as a patient advocate. He presents with," and then go on to list the reason for the visit. This introduction highlights the facts and provides the reader with context to Mr. Smith's daily activities and community involvement. The second statement about being a burden can be rephrased to something like, "Adjusting to a new functional limitation takes time. Maybe it would help if you hear directly from persons living with disabilities." This takes away the implicit bias that having a disability is a burden and that the person should feel guilt or any negative feeling for needing accommodations or asking for help. It also opens the door to a more productive conversation. There are other helpful comparisons on this chart. Take a moment to consider language that you have previously used when speaking to people with a disability. You might unconsciously state things that have subtext of abandonment or that determine a misleading prognosis. Healthcare providers frequently default to institutionalization and interventions without context when treating people with disabilities. Instead, the healthcare provider should actively think about maintaining and deepening a connection with patients with disabilities. Healthcare providers can share expertise and uncertainty in a respectful manner. Other communication pitfalls include the dehumanization of people with disabilities. Statements like Alzheimer's disease will slowly rob your mother of her memory and her dignity can be reframed to something more inclusive and helpful, like, let me share some tips on how to be a good friend or family member to a person with Alzheimer's disease. Devaluing the life of a vulnerable person by saying things like, are you sure you want the surgery and treatment, even though they won't cure your disability, harbors implicit bias that their life with disability is not worth treating. Stealing hope and disrespecting autonomy are other communication pitfalls that are led by unconscious bias toward people with disabilities. We can reframe these ideas by sharing hope and realistic planning, as well as guiding patients to supported decision-making. You can see the selected text on the left-hand side. They state that in a study of hospitalized able patients with serious illnesses, more than 1/2 of respondents believed that some health states, such as incontinence or requiring a feeding tube, would be the same as or worse than death. However, many persons with developmental disabilities have required these supports since birth, yet still have meaningful lives. They go on to discuss, after a period of adjustment, those who live with acquired chronic illness and disability typically rate their quality of life significantly higher than their physicians and caregivers. Self-reported quality of life for persons with disabilities is not significantly different than that of the general population. So to summarize, as healthcare providers, as medical SLPs, we should avoid making assumptions about patients' quality of life and avoid reinforcing patient or caregiver fears and misconceptions about living with disability. By being aware of unconscious biases, healthcare providers can better support all of their patients. We can improve access by reassuring all patients that we will care and advocate for them.